And it's okay. Can you see it?
It's okay.
It's okay.
I can see.
Very good.
Very good.
So I put this slide, and I would like to thank a lot, especially to Professor Huo Zhang. It's one of the worldwide recognized urologists in the world, and it's a real pleasure for me to be together with him and his team, and also to host him in this webinar. And I put here International Alliance of Urolithiasis, and because I discussed with Professor Zhang, and I think that this webinar could be under this umbrella. It's important, very important, this International Alliance of Urolithiasis. Also, I would like to thank a lot to the company that helped us, and they we choose an interesting, I think, and very close debate, and I think that everything, I hope that everything will be perfect. It's PCNL versus flexible laparoscopy. It's a debate in in the entire world, so it's very interesting, and I hope that everything will be perfect. And if you look here, it's a stone bridge. We try realize, together with Professor Zeng, we realize a stone bridge between Romania and China, concerning, of course, this problem. And of course, Professor Zhang, it's well known, it's vice president of the first affiliated hospital in Guangzhou Medical University. Of course, he's the president of the Urology Society of Guangdong province, and vice chairman of Urolithiasis section of Chinese Urological Association, and co-chairman and secretary general of International Alliance of Urolithiasis. And myself, Neil, here together, we try to make an important and interesting webinar. So there are a lot of remembers with Professor Deng in Julius meetings, and of course to be together there. It was a very nice occasion to share together our experience and of course our ideas. And I know that it's very close to you. The Happy New Year 2020 in China will be in February. So I put this slide. I like a lot this slide, and this one, you wishing you already Happy New Year. It's really nice to see these images, and it's a real pleasure for me to put these slides. And of course, I know you're, and well, it's very famous, the Kung Fu, Chinese Kung Fu. So I put here, of course, this position, and also, of course, Professor Zhang near me, to be together and discuss of course, what is the importance today in 2021 of mini PCNL, of course, and flexible laparoscopy. So the program seems to be very attractive and very well done. And I put here the program with session 1, session 2, and session 3, and closing remarks. And it is for me, once again, it's a real pleasure to be together. And with this bridge, stone bridge, this is very strong stone bridge, and I will sustain this connection every time, everywhere. So once again, thank you very much. Thank you to the company. Thank you, of course, especially to the team of Professor Zhang. And of course, I would like to wish great success of this meeting. So, Professor Zhang, if you want to also to discuss a little bit about these opening remarks. Thank you. It's working?
Yes.
Oh, thank you so much, Professor Gravett. We like your speech very much, especially the two cartoons. That's two Kung Fu experts.
Yeah.
That's well done, and thank you very much for your wishes to our Happy New Year. So here we welcome Professor Zheng Guohua to give us a speech.
Okay, dear Professor Kelly Watt, and Romania friends, and the Chinese friends, good evening, China Lao. Your opening remark is is excellent. I think every Chinese urologist was impressed by your opening remark because your cartoon, your Chinese Kung Fu, I like it very much. Very nice presentation. Actually, I love Professor. You do a lot of your laparoscope. I actually I listen to your many presentation in different international meetings, and you have a lot of experience for stone disease treatment, especially in uroloscopy. I think in the future we both and make a close cooperation between us, and maybe in the 2022, maybe COVID-19 pandemic is getting better. You must come to China, or must invite you to come to China to invite the department, and then I make a more and more exchange. Maybe I think maybe after this webinar, I must make a close and cooperation in the future. Thank you again.
Thank you, Professor Zheng Guohua. So shall we move to the academic part of this webinar? So the next session one, we have two moderators, Professor Liu Yongdang and Professor Bogdan Gavrilit. So please, Professor Bogdan Gavrilit.
Hello, everybody. It's a real pleasure to be with you today. And it's quite an honor. I would like to thank the organizers for this invitation. It's a great pleasure to be with you and to talk about some very modern, very up-to-date aspects of the urology, which you all know it's more than 90% of our practice. And digital flexible ureteroscopy, laser treatment are the very tips of the sword. So it's nice that we all have the opportunity to learn from each other, from our practice, and maybe improve the knowledge of the young participants to this course. So hello, China. It's great to be with you, and I'm sure we're doing a great job today.
So,
okay, good evening. In this session, there are two topics about the renal stone. One topic is flexible ureteroscopy, and another topic is PCNL. So the first topic is indications, tips and tricks in flexible ureteroscopy in renal stone. Are there limits in 2021? Now we welcome Professor Gravity. Welcome, please.
thank you very much once again. I hope that you can see my presentation. It's okay? It's okay? It's on the screen?
It's okay. It's okay. I can see very clear.
Excellent.
Okay.
Thank you very much. So what are the indications, tips and tricks in flexible ureteroscopy in renal stone treatment there are limits in 2021. Let's see. So my presentation, look, it's I have to uh, say that this presentation is also in Chinese language, and I thank a lot to Jeremy Lee because he helped us in order to be more simple for Chinese people to understand. So it's very good job, and I would like to thank you, Jeremy. So what about the new trends in our academic stone center? We have around 20,000 ureteroscopies in 2020 and maybe 6,000 digital. And if you look to the evolution, it's very clear that every day it's growing up. And we have, for example, in 2018, around 1,800 in a day, in a year. And if you look to the PCNL, yes, we still practice, but it's less and less. We have more than 8,000 in this moment, but okay, our center is especially for this kind of treatment. So about 30 years of experience. And if you look to the renal stones, I mean particular indications, of course I put here some of our slides in which can see the performance of the flexible ureteroscopes. You can see exactly the UPJ junction and also the stones. And these are the main indications you already know. It's not a problem. Of course, renal stone less than 2 centimeters. This is in Chinese. I like a lot this. And of course, in abnormalities and pylocalicial diverticum, also with lower stone calculate, and in renal stone between 2 and 3 and more. We treat more and more stones bigger and bigger. So if you look at the indications, also special indications, I put here some cases with morbidity. It's a nightmare for urologists to operate this case. And coagulopathy. A lot of patients we have with coagulopathy. Foreign bodies, calicial diverticulum, and body deformities, and of course, anormality, pelvic kidney, and heart stones, and also urinary diversion. So ureteroscopy is nowadays everywhere and in a very large population. And of course, you can think, okay, in a large stone, is possible a little ureteroscope, I mean, a little flexible ureteroscope can completely treat. This problem is also for the U, especially, I mean, for PNL, and because you still have vascular supply, important vascular supply. So let's discuss a little bit. Stone size, number, and there are limits for flexible ureteroscopy. Let's see in 2021 if there are or not. If you look at the evolution of indication, you can see 10 or 11 years ago, this is, of course, the guidelines, European Association guidelines. You have also in China this guideline. I'm sure that you know. It's a great evolution. And in 2020, flexible ureteroscopy is everywhere. Flexible ureteroscopy, it's, of course, here it's a debate, of course, for stones more than 20 millimeters. But also here, you will see that we must change this algorithm, maybe in the near future. If you look to this slide, I put especially for my friends from China. Look here. This is Champs-Élysées evolution. This is Dubai. And this is Shanghai. The question, can flexible ureteroscopy improve? Yes, it can. And you look to Guangzhou. Yes, your evolution is extraordinary. You can compare the old and the new Guangzhou, and it's quite impressive. Let's discuss a little bit about the stone size. You know, unfortunately, and once again, unfortunately, you know, the EAU guidelines and AUA guidelines, you know, we consider, we still consider largest diameter of the stone and not the volume. This is a real problem, and I fight for this, and I hope that maybe in the near future, the real evaluation of the stone is the volume, not the larger diameter. Of course, I put here a very important study in which you can see that in Europe, there are a lot of centers with many ureteroscopes, I mean many flexible. Look here, 22%, 3, 12%, 4, 22% also more than 5, and 10 about 10% more than 10 ureteroscopes, flexible ureteroscope in their armamentarium. And if you look to the preferred treatment, they prefer dusting, but also combining. You can see here the combination. And if you look to the every year modality of treatment, in Europe especially, you can see here that more than 55.5%, more than 200 flexible ureteroscopy in a year. It's important. And if you look to the flexible ureteroscope, you can see that also more than 23% they apply this treatment. I'm sorry, I think coming back. Now it's okay. Good. So if you look to this slide, also recently, 2019, published 2020, you can see, because also it's nice to have this translation, because you know there are a lot of urologists nowadays, they treat larger and larger stones. I mean, if you look to this slide, it's so important. 61% of high volume surgeons treat stones over 2 centimeters. And also, what about laser? Laser dusting. If you can see here, low volume surgeon also treat using this modality. I mean, with laser dusting. If you look to this slide from Bagley, it's one of the famous American site, American team. You can see here that they treat also stones uh, around 2.75 centimeter. Yes. And if you look, of course, they need multiple stage procedure. This is a problem. I agree with everybody that for ureteroscopy, for flexible ureteroscopy, if you extend the indication for larger stones, of course, you need, unfortunately. But look, 94% stone free, this is absolutely great. If you look to this paper from Olivier Traxet, I know, I'm sure that you know this name. He treated also stones of 6 centimeters, so huge stones using flexible ureteroscopy. Of course, he need, of course, multiple procedures. But it's possible. 96% 96% of such stones could be treated in such way. And if you look to Guido Giusti, also a great name in Europe, of course, one of my friends, and he treat also stones with large size to 3.44. And look to this stone free rate between 79 and 91. 1 month secondary and tertiary stone free rate. I like that also it's put it here in Chinese. So if you look to this paper, also it's important the size, and it's a correlation between the size and stone free rate is normal. If you look to the stone up to 1 centimeter, about 90 90 primary stone-free rate. If the stone is between 1 and 2, 78. If the stone is between 2 and 3, 70. If the stone is over 3 centimeters, 55. Is not so impressive. But the second and maybe third will be completely finish this problem. The second is so important, you know, the new ureteroscope. Because in this field, it is a great, an absolutely great, you know, evolution and perspective. And if you can see here a paper in which I was one of the authors, you know, from Europe, we analyzed 12,000 patients, and you look in 2014, it was 7 years ago, you can see that primary was used in 74%, flexible only in 15%, and both you can see here in this slide. So in our department, we have and we had all kinds of flexible ureteroscopes. I put here some of them, and I am so delighted to operate with them and all my coworkers. Very good, impressive deflection. But in the last 2 years, I changed a lot. We use especially single-use flexible telescopes, and I put here the new one from PUSEN. I operate with this last week. It's absolutely great, 75 French, and this new scope is really absolutely great from many points of view, and I think that it's really important to say. And if we analyze a lot, a little bit this procedure, you can see that, of course, analyzing my personal experience is clear. You know, you can see that between 30 and maybe 200 procedures, we can use this type of ureteroscopes, but I think that it's a real problem for reusable flexible ureteroscopes. The weak durability is clear for us. Weak durability, so it's expensive. Be very honest with you. But look to this slide. It's absolutely impressive today. You know, there are in 2020 single-use instruments for every patient. It's impressive. If you look, we have in our hands single-use duodenoscope. Absolutely impressive. We have also video laryngoscope, single-use, no problem. Each patient with each instrument. It's absolutely impressive. And if you look to the guidelines, our guideline in urology in 2020, you can see that now it's clear that single use has a very clear place in our technology. And I put here what we work every day. We work with PUSEN. So some images from my department. You know, you can see here a comparison between these flexible digital ureteroscopes, and you can see here, of course, you can see the PUSEN and XC stores, and you can see there are some advantages, clear advantages in moving, in angulation, and that's why I put these slides, because I think it's important to see the real life. I mean, our experience, our everyday, as you can see here. And even more, in 2018, in the Congress of Seoul, I mean, Congress of Société Internationale d'Urologie, it was a great debate between Professor Michael Grasso. I'm sure that many of you knows him, one of the great personalities in the United States, and myself. And it was a debate between, you know, I am a traditional urologist, Michael said, and I said, I am a fed up with breakage urologist. I mean, I like more single-use and robotic devices. So it was a quite interesting debate, and I remember the audience was full, full, full. So, what are the conclusion of single use? At least in the last 2 years that we applied. No sterilization, no cross-infection. It's so important. The maintenance, I don't care. It's not a problem. It's one patient with one instrument. Of course, it's the best deflection. Acute angle for lower pole is better. I showed you in one of my previous slides this fact. It's ergonomic, and you can really torque without problems. And once again, I think there are a lot of advantages. So, in our department, in our experience, after I told you more than 6,000, more than 20,000 ureteroscopies, I think that this single use is better to be used in unfavorable access cases. Because in these cases, sometimes you can book your reusable. So you lost a lot of money. One second. So also for large stone burden, for multiple stones, I mean for stagon, yes, we operated in the last year many stagon calculated with flexible. Of course, not in one session, but it's possible. And stone free in the end of the day. And also for lower pole, sometimes you need this because it's quite difficult to treat. Long duration of lithotripsy and the renal abnormality, it's so easy to use this and obese patients. Okay, what we have new? We have microureteroscopy. You know, not for this percutaneous, user. It's mini. Yes, we have also ureteroscopy, microureteroscopy. With less than 5 French. It's very, very interesting. And my great friend Galan from Spain, it's the leader of this, and there are some studies in this field. Fourth, laser news. Yes, it's a continuous evolution. It's so impressive. I put here some slides in which I put, for example, in 1985, I mean 35 years ago, there were the first machines, the first holmium laser machines. In 1998, the pioneers were Bagley, Bagley, and of course Professor Grasso. And in 2003, 5 years later, I mean about 20 years ago, I was together, and I put here this image with them to the 21 World Congress of Endourology with a course, educational course, ureteroscopic approach to upper tract disease. It's quite nice to put this slide. What about lasers? It's clear that in EAU guidelines and also in American guidelines, the holmium laser is currently the lithotripsy choice. It's clear. And you can see here we published 7 years ago this in urology. And of course, we analyze at this time the importance of this holmium laser. It is a great evolution of holmium laser. Nowadays, it's another story. It's another life. When I discussed with many from, they applied PCNL. Okay, I admire. It's okay. PCNL has great indications, but the majority of studies compare. Look here, the standard lithotripsy with short pulse with the newest PCNL methods. So look, if you look to high power and long pulse lithotriptor, you can see the great evolution of higher pulse energy, very high pulse frequency, and higher total power levels. You can see, and this evolution seems high speed of disintegration. Of course, if you look here, yeah, we have already 20 years 20 years, and look to the results from this that were published in 2001 using low power holmium, 20 years ago. And look to the results, 95 of stone were completely fragmented with stone-free rate as 3 months then of 92%. When? 20 years ago. Of course, I put here some of our experience, You can see here the evaluation of dusting versus basketing. And of course, there are some images of our experience from 2012, 9 years already, and in which we apply high frequency, low energy for lithotripsy into dust, and low frequency, high energy for lithotripsy in fragments. Look to this slide. It's high frequency dusting versus conventional. It's our experience. You can see here, I can destroy a stone 1 centimeter. You can see here in 30 minutes using this new laser. And you can see here, I can save 20 to 25% of time. So the problem with size is already resolved. If you look to this slide, yes, we have a recent innovation in laser lithotripters. We have MOSES, very clear. MOSES officially single modulated pulse with high speed video show 2 pulses, one for part the water and the second to ablate the calculus. So I put here normal and MOSES. It's really contact and non-contact mode is really a great method. So what in 2020 we have in our days, I mean, regarding the holmium, short or long, high or low, I mean, pulse duration, energy, and frequency, we have to combine them. We have to obtain the best results in order to disintegrate the stone. And here you can see 3 of our videos. You can see here completely destroyed. You can see perfectly. This is the real dusting. And here it's a stone in a diverticulum. You can see here how we can treat this one. And here a hard stone in which we use popcorn. If you look to the long pulse, here was 800 microseconds, here 200, and here 600 microseconds. So we can combine these and we can obtain stone free in the majority of cases. And if you look here, yes, in 2020, we have pulse width modulation. I mean, short or MOSES contact, long or MOSES contact, short or MOSES distance. It's absolutely great to see the evolution of this new possibility of treatment. But we need new laser. And this laser, maybe we need super high frequency with smaller fiber, with low energy. So we have in our hands today the thulium laser. And if you look to this thulium, it's another story. And this thulium seems to be 4 times better than holmium. And if you look to these slides, okay, high power holmium versus thulium fiber laser, it's quite different, great difference. Thulium is best. If you look to thulium fiber laser ablation, in automatic vibrating fiber. This is new. It's also quite interesting. If you look to this 2020, all are 2020. So you can see that both ablation efficacy and speed were higher than holmium. And this is, after me, one of the more important articles. I mean, a referee article, in which Peter and Olivier discuss about the importance, the new laser, I mean the thulium fiber laser. And if you look to if you compare holmium energy pulse in water, you can see reduce 37% for holmium, but for thulium reduce only 1.7%. It's a huge difference of efficacy. If you look the comparison of laser settings, if you look the frequency, it's unbelievable. For holmium it's 30 hertz, for thulium 2200 hertz. We are working with another tool. If you look to the pulse duration, 50 to 1300 microseconds, and here is 12,000 microseconds. You cannot compare. And if you look to this comparison of this specification, 3 to 4 times better. I mean, in order to obtain dust. And ultra small particles, because our dream is to destroy the stone in a very good dust. I mean, what means dust? Less than 1 millimeters. Because in the net definition, there are a lot of definitions. Less than 5 millimeters, less than 4, less than 3, less than 2. In my opinion, the real dust is less than 1. In this moment, you can see that, yes, we have the chance to have stone-free patient after maybe 1 month. Okay? And if you look the comparison of machine-related, look, this is TFL is 33, about 40 kilograms, and look to laser, 300 kilograms, huge difference. If you look also to the power, the consume for holmium, 10,000 watts, and for thulium, 10 times less. And standard power, yes, you can put this new thulium laser, near your iPhone. No problem. You can use without problems. So I think the safety of laser lithotripsy, it's clear. And I think if you look to this sentence, the TFL has a potential to compete and even to replace the holmium laser for laser lithotripsy. And look here, I put here my very good friend, Professor Scafone, very happy in 2020, very happy. Look to Gildo, Professor Gildo also, one of the best urologists in the world, in Europe, very happy. And I put here our experience. Look, it's on LinkedIn, about 8,000 urologists. And, they appreciate a lot, our experience, this super pulse TFL, and I think that this is quite important. Look, some images from Sanador Hospital. I mean, in which we applied last year this new TFL. And finally, what can I say? I say that best dusting effect, faster for every stone, no retropulsion. This is so important for us. Best irrigation, we need to irrigate every time, and best view is absolutely clear. But we have indication, yes. Limits in 2021, I don't know, maybe, but look to this sentence. I put also here, I'm so happy because it's also in Chinese. No contraindications for flexible ureteroscopy. If I'm thinking a little bit to the contraindication of percutaneous approach, oh, it's another story. You still have a lot. So look to these patients. Unfortunately, we have such patients, 13% of adults in the world are obese. And look the prevalence in Europe, but look to North America, 36%. It's unbelievable. They are like this or like this. So how can you treat these patients? I mean, without flexible ureteroscopy. And look the map. Of course, it's absolutely impressive. This is North America. this is Europe, and this is China. In China, so I don't see so much obese. Look, the comparison. So unfortunately for us, the evolution is like this. I mean, with a lot of obese patients. And you look to this obese patient from our department, between 90 and 95% overall stone free. It's absolutely great for this patient. It's a very nice operation. And I don't know what it happened with PNL. I don't know. Maybe it's possible. Maybe you need, it's a challenging cases, needs maybe special tools, maybe great experience. I'm sure the Professor Zhang could reply to me, but really, it's a problem like this, for patients like this. What about anticoagulants? Yes, I put here, a map with anticoagulants in the world. And you can see a lot of patients, an impressive number of patients are anticoagulant. So look to ureteroscopy. Even some years ago, Professor Preminger and John Denstedt, there are two giants in endourology from United States and Canada, and they express the fact that upper urinary tract calculi with uncorrected bleeding diathesis can be safely treated with flexible ureteroscope. So I think it's so nice to see this experience. You cannot compare. So my question, PNL, yes, where the limits? Anticoagulated patients. All renal stones in such cases could be treated using percutaneous approach. I don't know. I'm not sure. But for such patients, all patients could be treated with using flexible ureteroscopy. No contraindication. This is very clear. And I put here also a giant in percutaneous approach, Professor Mahesh Desai. And he clear demonstrated that the contraindications still are important for PCNL. I mean, also for bleeding disorder and other possibilities. So what about calcium diverticulum stones? Yes. Horseshoe kidney? Yes. Pelvic kidney? Yes. I mean that flexible ureteroscopy, it's very important to be indicated. And I put here only our experience, 61 cases, our experience published in 2011 in urology, in which we can describe the importance and very nice demonstration of flexible ureteroscopy in these cases. So, in stone associated with renal abnormality, yes, I'm sure that PCNL and flexible ureteroscopy could be together. Yes, I agree. But, there are some limitations for flexible ureteroscopy. No, zero limitation. Look to this slide. How can you treat this patient with thoracic kidney? Look here, with stones, with percutaneous approach. I don't know. And this case, with multiple stones everywhere in the horseshoe kidney. Maybe it's possible. Multiple punctures using flexible together with percutaneous, I don't know. But it's a huge difference between flexible ureteroscopy, so easy, so nice, and so clear. And this is a stone in a tertiary calyx, So look these patients. It's possible to treat these patients here and here. Are you sure that percutaneous approach is possible? I don't know. Maybe in your experience, maybe some, but not in the real life. And look here the videos of these patients. And if you look at this kind of patient, you can see exactly that PNL, I don't know, there are limits. Of course, I'm sure that challenging cases, yes, you have. And my question is, all important deformities could be treated using percutaneous approach? I don't know. But look here, all important deformities with stones could be treated using flexible rotoscopy. This is clear, absolutely clear. Look in pregnancy. Okay, in pregnancy it's possible to be a complication, you know. And I put here some of publications, and of course I put here our experience. 70% of cases, okay, conservative treatment. I agree. Where heteroscopy plus holmium, yes, we apply because it's possible. It's possible. PNL, I don't know. Probably yes, but I'm not sure. It's a challenging case. But flexible rotoscopy, it's so easy. It's not a problem. It's not risky. Of course, in very selected cases, I have to say. And I put here also the solitary kidney. Yes, agree. I agree with you. It's possible, no problem for percutaneous approach and for flexible. I agree. It's not a problem. But look to this analysis. You can see the complication rates, 26% with PCNL, and only 15% using flexible rotoscopy. So what I prefer? I prefer, unfortunately, flexible rotoscopy. So if you look to this case with nephrocalcinosis, I put here two of our cases in which you can see exactly how can we treat. And you look here to the radiology, a lot of stones here, after second here, and stone free in the end of the day. Is possible only with flexible rotoscopy. It's possible. Yes, it's rare, but there are some cases. And look to this slide. PNL, never, I think, because you cannot treat this kind of patients using PCNL. I think flexible rotoscopy is, look, here and here, no stones, no stones. And also this case, here, if you look, and here, no stones. Yes, what we have in our hands, we have robots. It's a great evolution. And there are limits. I don't know. I'm not sure that there are limits. Because from 2008, and if you look here, I was one of the promoter of robots in 2013, and 2015 I introduced in Romania. And it's another story, because a lot of these presentations were the best poster, best video in all congresses. And if you look to the robot advantages, there are a lot of advantages. I mean, best perfect position, no radiation, no radiation, because you are not here. Only a robot, it's perfect, and also ergonomic control. Look to me, I'm here. I feel relaxed. I feel so good. I have a Coke near me, and I can drink Coke, and I operate. I drink, I operate. No problem, It's so easy using this method. In AUA 2018, of course, this abstract was also with the best poster. But we still have problems, be sure. And I want to be very honest with you. We have problems. We have complications, still complications. If you look to this slide, my headache is the stone-free rate after flexible rotoscopy. I mean, the residual stones. Yes, I agree with you that flexible rotoscopy cannot give you real stone-free patients. This is, for me, is very clear. Of course, after 1 month, you can obtain. And if you look to the residual fragments, of course, in area guidelines, it's a strong recommendation to wait a little bit, 1 month, or between 1 and 3 months. Okay, but what could happen with these stones? Could be, it could disappear in 40% in dust, and 21%, so even dust could be dangerous. So this is my very honest problem in this moment. I have to say, that this dust could be a problem, even in the best hands, even with the best fragmentation tools, you know, and especially presence in stone, lower pole stone is difficult. It's difficult to obtain complete stone free. Look to Margaret Pearl. Margaret Pearl, you know, it's one of the also best urologists in the United States. She is very, 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 you know, reserved. If you look here, stone less 5 millimeters, stone between 5 and 10 millimeters, 58% is huge. I mean the residual. I mean the stone after flexible telescopy. Of course, if you compare the complication, it's clear 3.5 here. And if you look to our we published in 2020. I mean last year we have renal pelvic and look to lower pole. Unfortunately, only 75% stone free. I mean 4,000 flexible procedures, but the complication 44.2 and Clavian grade only 1.1 for one. So it's nothing. So it's so important to know. And look here, it's yeah, this is important five. I mean 1,500 pages. I mean there are 3 volumes in textual endology in which I put these complications. And also, if you look to urotelium, yes, it's possible to obtain something like that. When? If the thermal injury, because when you use not only holmium, but also thulium, I put here the last publication with holmium and thulium, we can obtain this, you know, without irrigation. This is a real problem. So, finally, I think that for us nowadays, in our practice, we have less than 1% complications in our experience. But if you compare with 30 years experience, all the complications described in the literature, we already saw in our practice, unfortunately. And now it's yes, the percutaneous nephrotomy. Look to the Clavian, 11%. To the look to the bleeding, 8%, and another. You cannot compare. You cannot compare. And of course, I was one of the authors in this study in which we demonstrated that 10% of patients develop fever post PCNL. So I think this is my last slide. Flexible laparoscopy for the evolution for near future. I'm so happy because we have also in Chinese. It's expanded indication, stone size, number, position, new ureteroscopes, new lasers, new robots, even less complications. Thank you very much for your attention.
Okay, thank you very much for your excellent presentation. Because there are new flexible ureteroscope, new laser, so there are low limits for flexible rhinoscopy. Thank you very much.
Thank you very much.
Prof. Bogdan Gravelit, you are the moderator.
Yeah.
So we should continue with the second presentation, I think, and then discuss questions at the end. So we'll listen to our next guest.
Professor Zeng.
Professor Zen?
Yeah, I can hear you. Okay, share the screen. Okay, you can see slides. You can see slides.
Yes, it's perfect.
Yes, absolutely. We're listening.
Yeah. 我放的最 最前面一张我放到最后面一张。Now it's okay, Professor?
Perfect. Perfect.
Okay.
Very good.
Okay. Okay. Dear friends, dear colleagues, good evening. Just now, Professor Gabriel gave me a really nice, really excellent presentation about flexible ureteroscopy. Now, I will talk about indications, tips, and tricks in PCNL in renal stones treatment. Are there limits in the 2020? Okay, according to EAU and AU guideline, I think, and more than 2 centimeters renal stones is the first treatment for the PCN procedures. But sometimes in your real practice, sometimes it's less than 2 centimeters renal stones. Sometimes it's suitable for PCNL, for example. But this case is male, 40 years old. You see this stone is low pore stone, diverticulum stone. This is not too large, it's less than 2 centimeters. And because first I try to use flexible ureteroscope, but it's small, it's acute AP angle. Maybe it's very difficult to reach this stone for low pore stone. For this, I must do PCNL. Usually for PCN, the first puncture is low pore puncture with endofluoros and X-ray, and then remove stone. And then I see stone. I cannot find this diverticulum stone endoscopy view. So I must make a larger puncture. Larger puncture is endofluoro and the direct puncture low pore diverticulum. You see, I make a larger puncture and remove a stone. This is, I think, is total tuberous. This is a larger case. Is 2 years old girls, right kidney stone, 2 centimeters. Because this stone is too large, it's less than 2 centimeters. Pediatric renal stones less than 2 centimeters. But the first choice must shock away. But the shock away is failure. But after PCNL, the stone composition analysis is 16 stone, because at everybody know 16 stone is very hard, is not suitable for shock away. You see, this is preoperative KUB and the IVU. You show this stone in the pelvis, this CT scan, and for this case, I make puncture from X-ray and then from that's middle calyx, puncture from middle calyx and dilate the 14th flange. I use my new technique, super mini PCNL, and the one session and the total tuberous, and for this you see is no leprous tumor, no DJ stand. This is really useful for pediatric renal stone, because sometimes put a DJ stand, you must ask the girls to come back to remove DJ stand, and maybe she must need a larger anesthesia. This is not too bad. And for total release, and there is one session, one surgery is stone flare, is better. So make a summary. For PCN indications, the first indication must be more than 2 centimeters renal stones. But sometimes, as Professor Pervilet said, sometimes for more than 2 centimeters, maybe you do flexible. Maybe it's okay, but for flexible for more than 2 centimeters, maybe it's need a two session flexible ureteroscope. Maybe it's okay. But the other indications for PCN procedures for more than 1.5 centimeters low pore stone and symptomatic diverticulum stone and any size of stone failure to the shock and flexible uroscope. And more than 1.5 centimeters upper urethra calculi, especially in impacted upper urethra stone. Any size of urethra stone that have failed retrograde treatment. Sometimes you cannot find the orifice of urethra. Sometimes orifice of urethra is really, really narrow. You cannot go into the going up. So you must change the treatment modality. Next, we talk about anesthesia for PUSEN procedures. And generally, in PUSEN anesthesia is general anesthesia is routinely used in the PUSEN procedures. Epidural, maybe you can use. Sometimes you can local anesthesia. For example, paravertebral anesthesia is for some case. Actually, during the COVID-19 pandemic, we try to perform the PUSEN and paravertebral anesthesia because they have too many advantages. Because low risk cross infection of COVID-19, safety to the doctor because you no need to use the ventilators. Safety to the patient. The patient is day surgery, no need to stay overnight in the hospital, and this sometimes you can do total tubulars, and the patient cannot come back to remove the dissident again, and these disadvantages maybe for this anesthesias need some rolling cough, and this kind of anesthesia is not suitable for every patient. It's only for like these patients is a young patient, no comorbidity, and the procedures is repeated, is finished is in 90 minutes, is short time, not too long, maybe 2 hours, 20 hours, maybe no good. This and another is patient is not excited about this surgery. Okay, it must relax and then you can do it because when you do PUSEN procedures, patient is always awake. Like this patient is under paravertebral block. You can after operation, and the patient is from the operation table, and then can go back from OT to the ward, and then post-operation 3 hours, patient discharged, they go home. He cannot stay in the hospital. And the next I talk about PUSEN puncture technique. Actually, a good puncture means good PUSEN procedures. There are main technique for puncture techniques. The first is fluoroscopic guidance and the ultrasound guidance, and sometimes it's combined approach. For floor guidance is the most used technique in the PUSEN procedures, and it is very familiar to the most urologists. And then he can demonstrate the collecting system very, very clear, very, very delayed in the details, but it's risk of radiation exposure, sometimes to staff, sometimes to patient, is too much radiation. And for ultrasound guidance is low radiation. Sometimes you can see structure between the skin and the kidney, and some you can see really clear anatomy around the kidney and the organ. Sometimes you can use pediatric patients, but sometimes pH sound guidance is very difficult to confirm guideway position, and especially for load dilated system, it's very not clear. And it's very difficult, very difficult to confirm the tips of dilator. How to open these drawbacks? Maybe you can use ORC in the needle, assist in the pH sound guidance puncture technique, and then I like to use the combined approach. This is modified ORC in the needle sets. This puncture needle is only 4.5 French, and the optic fiber is really, very fine. It's 0.9 meters. And this is three post hands like this, and the fiber is reusable. And all this needle or this handle is disposable, single use. I can show this video for every board. You see, pH sound guiding with this ORC in the needle. You can see the needle is come here. And here is maybe, I think it is the middle calyx. And then I with syringe use, and then I connect this handle. And then insert this guide wire, optic fiber. This fiber, and I can see this calyx. And the larger channel, I insert this guide wire. And you see as the guide wire is, as the guide wire is in here, is inside, and then you can make a dilation. You can make a dilation for mini poke. You can make a dilation for stent poke. Is as you like. You see, I do this. You use this SMP 14 French. Okay. This is very safe. Sometimes you can use this technique. Actually, I would like a combined approach because I make an initial puncture is under pH sound guidance, and then guide wire insertion and the dilation was performed under fluoroscope control. Because this is really less radiation and really safe and really successful and more activity. Which is better for this three guidance puncture technique, fluoro, totally pH sound, and the combined guidance. Actually, maybe 3 years ago, our group finished this this trial, compared this three puncture technique. You see, this was published in the BJU International Journal. It's for simple kidney stone score is 5 or 6. It's okay. pH sound is safe, and is safe and effective as X-ray and combined with low radiation exposure. But for more difficult little stone scores is 7 and 8, maybe. X-ray and combined is more active. When you need multiple checks, maybe is X-ray is more bad than the pH sound. So next I will talk about sites in PC, exercise in PCN procedures. Actually, I think PCN must divide into two kinds of according to the exercise. The first is standard PCN. This exercise more than 24 French, and the another is mini poke, as less than exercise is less than 18 French. For mini PCN, there are too many different techniques: UMP, micro, super mini, MIP, and so on. And I think mini PUSEN technique have become more and popular in the recent years, and in European, in Asian, in American maybe. But most of urology always worry about two problems. So sometimes all urologists is worried about maybe you do more than 2 centimeters renal stones, maybe have a very long operation time. And then you always use pump flush the stone fragments, maybe it's higher intrarenal pressure, and they maybe cause more and more flavor and more urosepsis. Actually, is too many meetings, too many workshops, or debates. This is two problems. It's very low evidence publications. So in the last year, where our team have finished this clinical trial, compare mini PUSEN and standard PUSEN for 2 or 3 centimeters renal stone. And you see this primary endpoint is 1 session stone free. And the standard PUSEN is 24, mini PUSEN 18 French. And compared to standard PUSEN, mini PUSEN achieves stone free is the same. There's no difference. And then for mini PUSEN, reduce blood loss and the post-operative pain is 2 days, and very short hospitalization. And actually, everybody worry about this high pressure may cause too many infections complication. You see, this is that's the increase in infections complications, but for mini PUSEN have longer operation times. This is true. How to manage this problem for mini PUSEN have a long operative times? I think you can use suction PUSEN techniques. When I mentioned that this suction technique in PUSEN procedures, you must think about EMS lithotripsy. Actually, yes, EMS lithotripsy has suction technique in the probe, but this probe is too large. It's not suitable for mini POC. The mini POC axis size is only 18 French and 6 French and 14 French. You cannot use this suction probe. So we developed a new suction system for mini PUSEN. I named this technique. I think this is this technique is super mini PUSEN SMP, and then another is enhanced super mini PUSEN ESMP. I think these 2 techniques, the main innovation is suction shears. This is really useful. It's totally different from EMS lithotripsy suction probe. What is difference between SMP and ESMP? I think the first nephroscope is different, size is different. SMP is 18 French and the ESMP is 11 French, and the sheath is different. And for SMP, this is 2 layer sheath, and the 2 layer sheath, and the 14 French, and the irrigation flow sheath, and the suction flow sheath. This is one-way suction. So you remove stone fragments very fast, very effective. And for ESMP is only irrigation flow in the scope, and the suction flow sheath is 18 French suction sheath. And the irrigation is for nephroscope and for ESMP. For the lithotripsy and for SMP is laser only, and for ESMP you can use laser, you can use pneumatic lithotripsy. What is indication for SMP? Let me this article is published by BJU journal. This SMP is 2012. Milli-PCN is 50,000 salt, and the ore stone is more than 2 centimeters real stone, and this is multiple international multiple center stone start is 20 hospital come from 5 countries: China, Philippines, Qatar, Uganda, Kuwait. This is outcome, and compared to milli-PCN layer for 2 or 3 centimeters real stone, SMP is better than milli-PCN, higher stone flow, lower complications, and short hospitalization, and high tubular rate. And for 3 or 4 centimeters real stones, SMP is okay, but it's longer operation time. But for more than 4 centimeters real stone, SMP is really bad than the milli. So it's very clear. Indication for SMP indication is for less than 3 centimeters real stones. It's more than 3 centimeter real stones is difficult. Maybe it's too long operation time and too many complications. Well, what about its indication for ESMP? Okay, let's see. A larger publication is published with the World Journal of Urology, and this is RCT, but considered too much. Traditional milli-PCN is 47, and the ESMP is 46. And you see, for more than 3 centimeters real stones compared to the milli-PCN, traditional milli-PCN, and the ESMP has a short operative time and the high stone removal efficiency and the lower pressure, then it causes less post-operation and low post-operation favor and the low urosepsis. So for ESMP indication is for more than 3 centimeters real stones. I show this some special case for everybody. This multiple axis is SMP for standard Stegahan stones. This is mere 50 years old bilateral Stegahan stones, and you see the large hospital is underwent two axis PCN. So left, you see not right, left side, and ask a stone flay this time. Oh, Dorian ask a stone flay. For this patient, for this is for flexible is very difficult. For PCN, maybe you can do it. You can try it. For this, I do this. You see, 1, 2, 3, 4, 5 punctures, and 1 session stone flay. See, and the other is ESMP for 3 centimeters real stones. This case is 6, 7 or multiple stones. The left side, you see this left side, and the right side is atrophy. It's low function. It's low function. You see, this is multiple stone, and you see I make a puncture in the upper pole, and then I go into this, and there's one punctures, and not too much time for operation time is 65 minutes, and the version is stone flay. Too many stone. You can all stone is suction out the stone, not by pump flush the stone fragments. It's very fast. You see, this is impossible. And the other ESMP is femur. Is 40 years old, bilateral multiple needle stone. This infection stone and always recurrence. She asked me remove the old stone, and the so that can prevent the stone recurrence. You see, this is left side. The first I do left side. I think left side is easy, but actually it's really difficult. You show you. You see, this is too difficult. Is stone is located at different calyx, and you make a puncture. You can not only remove this stone in this calyx, and you cannot remove this larger calyx. You see, 1, 2, 3. I make 4 punctures and the ESMP, and then remove stone flow and the tuberous. But I put the digestion 2 weeks removed. But the another case is left kidney multiple cell, and 2 weeks ago, and to 1 session PCNL. This is and then ask remove the wall stone, and 1, 2, 3. I make puncture 1, 2, 3, 5 punctures. 5 punctures remove all stone. You see, but for this case, not for tuberous. I put 1, 2, 3, 4 tubers and the digestion. Okay, I think suction technique in PCN is have too many advantages. The first, higher stone flow and the less complications. For example, too less bleeding, too less infection complications, and then has cost-effective treatment for stone, for nail stone. So I think in the future, suction PCN techniques solve the limitations for the mini PCNL, and I think it must have a good future. Okay, thank you, everybody.
Thank you so much for our two experts in the excellent presentation in the session 1-to-1 for the indication and. Shall we discuss in this session 1? Any questions?
Yes, so first of all, I would like to congratulate Professor Zhang. This was absolutely remarkable, quite an impressive experience, and congratulations for the continuous effort of you and your team. Actually, I have 2 questions. The first one regards mini PCNL. There's an ongoing debate on its advantages in the international meetings during the past few years. So the question would be when not to do it. So what would be, in your view, in your experience, according to your daily cases, what would be the situations in which mini PCNL, either micro or mini or whatever, is not a good option to treat the patient?
Very interesting question. Actually, for mini PCN, actually sometimes for mini PCN is indication is partially is same as the flexible uroscope. For example, it depends on your doctor's experience. Sometimes you can do flexible very rare. Maybe this patient come to you is less than 3 centimeters. Maybe you can do flexible. But for me, I have too much experience. PCN technique, maybe for me, for less than 3 centimeters, I do PCNL. And the secondary depends the patient's choice. The patients, I don't like come to hospital many times. I don't like 2 times surgeries, operations. I only 1 time so operation and then remove my stone. Maybe you must do PCN, and sometimes patients I don't know, micro PCN, yes, it's like inject, but I don't like you make a puncture in my kidney. You can do flexible. But sometimes it's dependent patient's opinion. The last you depend your instruments available. Sometimes I have low. Sometimes in China, maybe in countryside hospital, it's low flexible. It's only PCN instruments. Sometimes you must do PCN procedures because depend different factors. Maybe I think so.
Okay, thank you for your question. And the second question is about the type of anesthesia. This is also depends very much on the view. For example, in Europe, Western Europe is very much towards general anesthesia for all endourological procedures. This is a reality for either retrograde intrarenal surgery or percutaneous procedures. On the other hand, Eastern Europe leans more towards spinal anesthesia because spinal anesthesia is fast, is quick, it doesn't need intubation, it doesn't need ventilation. And now there's an ongoing discussion about a new trend in light of the COVID pandemic, which you mentioned very nicely in your slides as well, that spinal anesthesia is becoming more and more fashionable because it involves less ventilation. So my question to you would be, because you've mentioned regional blockade, you mentioned local anesthesia, which by the way is a very brave way to do it. I have never tried it, so congratulations. Courage. You must have some pretty obedient patients. I don't, so that's the thing. But anyway, the question would be if you tried spinal anesthesia as an approach for the percutaneous procedures, and did you find any significant difference by comparison to your average general anesthesia cases in terms of patient comfort or doctor's comfort or the comfort to do all the maneuvers that you need to do during the percutaneous? So could spinal anesthesia be like a middle way solution for this?
This is a very good question, because for anesthesia, maybe actually in our department, maybe more than 80% patient is general anesthesia, actually. But you know, in the last year, in the COVID-19 pandemic, and I tried to use this local and spinal anesthesia. I think sometimes not for all patients, for local anesthesia, sometimes for selective cases you can use. For this patient is pelvic stone and 2 centimeters, and you can remove it really, really fast. Maybe for me, maybe half hours finished this operation, maybe tubeless, and then I can use. But this patient is young, not too old, no comorbidity. Maybe you can use. You can try. Not for all stone, not for all patients. Selective cases you can use, because the patient is good. The patient is, I can see. I can see stone is break and remove. Is really happy, but really less patient is really really tension. I don't like. I don't like you do operation. I ask sleep. I need relax. Maybe you can come complication with patient. Then you can do it. And not too much for department. Sometimes do it.
Okay. We have a question from the audience, from the participants. They ask you for a few technical details about the suctioning PNL. So what does it actually consist in, and what does it do? What's the advantage for the operation, the suctioning PNL? It's a question from the audience.
Okay. For suction technique in PCNL, first for mini PCNL, exercise is too small, maybe 18th range. usually traditional midi-PCN, you must flush stone fragments with pump. The pump is, you see, this pump, this is possible. It's really, sometimes you flush this stone fragment inside in the sheath, half is out, half is come back to the cavity. So it's really not active, but with suction, you suction and then you can suction stone fragment out very fast. This is active, not passive. Then you can shorten the operation time. The secondary, with always continuous suction, maybe pressure is really low. I check this pressure, it's really low. Average pressure is less than 20 millimeter mercury. It's really low. You see, it's backflow cutoff is 30 millimeter mercury. I think this is two advantages. Thank you.
Okay, thank you very much. Are there any other questions?
I have questions for Professor.
Please.
Cabrera. I've been to the Spain to micro URS, but for I think this is good for pediatric urate stone is a good technique, but you do this micro URS. What is the best indication for this technique? The indication, but sometimes for adults is okay. Pediatric, I think it's okay.
Thank you very much, Professor Zeng. Once again, I was impressed by your cases. Really, you have challenging cases in which I think that is very good. You know, for us, at the moment, flexible retorsion such cases, it's quite difficult. You know, a lot of sessions. Of course, I was impressed by the fact that you must utilize 4 or 5 tracks. Wow. For me, it's a little bit too more, too much. But okay, I agree with you. The results are very good. Coming back to microureteroscopy, you know, it's a study in Spain, and it's conducted in the teacher is Professor Karam. You know him from and they started 3 years ago. I didn't work with kind of micro ureteroscopes, not yet, but they apply this especially in children. I mean, having this diameter less than 5 French, the ureteroscope is so good for pediatrics. I think this is the main indication. Maybe it's possible for stones, but not in my view, not for large stones. It's clear. So this is my question to you, and I appreciate a lot once again your question, because yes, in the beginning I was so very attracted by this micro microscopy, but I'm not so sure that, you know, the indication. I'm not so sure.
Because in micro URS, I think is best suitable for pediatric urate stone, and sometimes for femoral distal urate stone. Sometimes for older people, maybe with BPH, maybe it's very difficult to go in. Maybe I think I never do it. I never do it. I never do this micro URS.
Yeah. Me too. I didn't use, but you know, their first results are very interesting. It's good. It's a good option sometimes.
Yeah. I think this instrument is the same as Michael Pork. Is the same instruments is the same.
No. It's a ureteroscope, very skinny, with only one channel, and you know, you can destroy the stone with laser. Only this.
Oh, it's different. I know. Okay.
Exactly.
Yeah.
Exactly.
我们进到下一个。
Okay, gentlemen, shall we move to the session 2 according to the time limit? So we have session 2. We have 2 moderator, Dr. Zhu Wei and Dr. and Matascu. So please host session 2.
Good afternoon. I think it's time for a debate regarding 2 centimeters lower pole stones. And Professor Zeng and Professor Javlete will discuss either the PCNL or the flexible ureteroscopy are the best choice in such stones. So please, Professor Zeng will start with his choice of PCNL.
Okay, so next we go to the second session. This section is a very exciting session, seems like a debate session. The topic of this session is for treatment low pole stones, which is your first choice? And we are lucky to see the 2 stone disease births in this world. One is PCNL birth, Professor Guo Huazhen, and another one is the flexible ureteroscopy birth, and Professor Garrett, and to share their different opinions in this kind of question. So first, let's welcome Professor Guo Huazhen to share, to make his presentation, and his opinion is he will use mini PCNL in treatment of this kind of stone. So Professor Zeng, please.
Okay, I can share the screen.播下来也行。全屏。Okay, where I start the debates. 2 centimeter low pole stone. My first choice is okay. Okay, before my presentation, we must know how to evaluate the treatment of person. The first, I think, is efficiency. The second is safety. The last is cost effective. For stone disease surgery, efficiency means stone free, and the safety means less complications. Okay. The first I talk about efficiency stone free. You see, compared to mini PCN for less than 2 centimeters real stones, because, this is 1, 2, 3, 4, 6 publication. You see, stone free is in publications the lowest is 80%, and the highest stone free is almost up to 100%. And the second is the flexible ureteroscopy for less than 2 centimeters real stones. You see, it's 1, 2, 3, 7 publications. The lowest stone free is only 73%, and the highest stone free is 96%. From this meta-analysis, You see this compared to the flexible uroscope, mini PCN has a higher stone free. And this larger meta-analysis for solitary stone, stone flake is the same is two treatment. So the mini PCN and the flex is the same. But for multiple little stones, PCN, mini PCN has a higher stone free. This is the last paper, another paper. Flexible is a higher treatment rate for local stone, and the mini PCN is a higher stone flake for local stones. So the second I talk about is complication for mini PCN and the flexible uroscope. You see, mini PCN for flexible, for stone flake, local stone flake, for less centimeters restaurant, you see, mini PCN is an independent risk factor for post-operative complication. For this paper, mini PCN have more and more complication than flexible uroscope. And this another paper is for less than 2 centimeters stones, means mini PCN has higher complications. And another is mini PCN again has a higher bleeding risk compared to the flexible uroscope. And the last among come is cost effective. The cost effective, you cannot only compare the total medical cost. This is not good. You must compare EQ. EQ not means motion quotient. It's effective quotient. It's totally different. That means higher EQ is best cost effective. Let us see this paper, this publication. You see, for RIS, for flexible uroscope, EQ is 0.5. But for mini PCN, EQ is higher, is almost 1. So SMP have a higher beta EQ because it's a faster stone free, a lower the treatment rate, and no major complications. So, make a summary. For less than 2 centimeters stones, free window. You see, mini PCN in efficiency is better than the flexible, but the safety flexible is better than the mini PCN now. And the cost effective maybe mini PCN is better than the flexible uroscope. So mini PCN is not a complete window. Okay, next.
Okay, so Professor Zheng, to our surprise, Professor Zheng told us that mini PCL is not a complete complementary in treatment this kind of stuff. So next, let's welcome Professor Garrett to make presentation to share his opinion. The flexible uroscopy is his first choice in treatment of 2 centimeter local stone. So welcome, Professor Garrett.
So thank you very much once again. And you know, I put here this slide, and I start with this sentence: 2 centimeters lower pole stone. My first choice, okay. I put here I like flexible retoroscopy, but I have to say that very close for me is mini PCNL. I like a lot mini PCNL. So I think that it's a wonderful tool. So we must be very, very, very clear in our discussion. And of course, we must be very honest. You know, I like flexible ureteroscopy. Why? Because for me, it's a driving on a highway. You know, I don't have no contraindications. I can repeat the procedure. It's not a problem. So if you look to the PCNL, wow, it's a hole into the kidney. So that's why it's one of my sentence. Another sentence. You know, I use all these ureteroscopes that you can see here. You know, more than 6,000, and also the new one, the newest. I mean, the U-scope for PUSEN 7.5. And I'm so like Professor Zhang. You know, I appreciate a lot once again, you know, this great personality. You know, he said, I like this because I have experience, because I have instruments, because I am convinced that I can offer to the patients the best. I completely agree with him. It's very, very correct. Look to what we have in our hands. And if you look to the, you know, guidelines, it is clear that look to the composition before treat the stone, and look to the high risk bleeding procedures. You know, percutaneous nephrolithotomy is in this category. Of course, for flexible heteroscopy and PCNL, okay, we can discuss about one factor for SWL. And yes, I agree, I completely agree that, you know, initial stone-free rate, final stone-free rate, and of course, less of multiple treatment are all in favor or mini PCLL. I agree with you. But if you look to the complications, oh, it's another story. You have here all the articles published in which you can see overall complication, minor, major, transfusion rate, all are in favor of flexible ureteroscopy. And if you look to operative time, yes, for operative time, mini PCNL it's in favor, it's clear. But hospital stay, no. Yes, I was impressed by the case presented with, you know, with local spinal anesthesia. It's amazing. But if you compare with the normal PCNL patients with normal flexible heteroscopy patients, this is the truth in the favor of flexible ureteroscopy. And let's talk a little bit about this 2 centimeter stone. I suppose that Professor Zhang is completely agree with me. If you look to this stone, look here, 2 centimeter, it's okay. But if he has 2 or 1, is 4 centimeter cube. If you look to the new EAU formula, I mean the volume is 2.097. If you look to this stone, also 2 centimeter. It's correct, it's correct. But this is 211, and the volume is only 1 centimeter. I can destroy this stone in 40 minutes. So if you look to this slide, you can compare. Now you can know, you can see that this evaluation of size of the stone is not correct. Really is not correct. The correct is to evaluate the volume, because it's another story, like I demonstrate to you. So I put 1 second in this one because I can destroy in 30 minutes 1 centimeter cube. This is a stone that I show you, and I can realize a real stone dusting, and this is okay. You can also realize a very good treatment of this stone. Okay. Yes, fragmenting and dusting is better now. If you look to large uric stones and monohydral stones, because it's quite different, you know, the structure. We discussed the size. It's not correct. because the size is not everything. The volume is correct. We discuss about the stone of 2 centimeters. It's not correct because the structure is correct. You know, is uric stone, calcium monohydrate, dihydride, and another. You know, it's totally different. The possibility to treat for us, especially, I mean, for flexible retroscopy, this kind of stones. So you cannot put together. This is my message. You cannot put together all stones over 2 centimeters or near 2 centimeters. It's are good for PCNA or are good for flexible retroscopy. It's not true. So if you look to this slide, it's clear that thulium gave us the possibility to be 1.5 to 4 times faster stone ablation. This is very clear in favor to treat endoscopic treatment and not realize 3 or 2 or 4 percutaneous punctures. And if you look to this new paper, you can see that we have nowadays in our hands the laser fibers very thin. We have also 150. We have also 50. So it's so easy to reach all the stones in the lower pole. But I think that, you know, we be very honest. You know, I feel in 2021 that the disintegration of lower pole renal stone is no more a problem. We can destroy without problem such with the best tools, of course. The problem for me remains residual stones, even residual dust, because we don't know what happened with this dust in time. We know, but you know, it's a problem. And look to this image. You know, I put this image to all my flexible ureteroscopes for lower stone. And you can see so important is the young angle, ILC, IWW, IUPA 1 and 2, and RIA. So this is technical point of view. You cannot discuss the treatment of lower stone without this. You cannot compromise a wonderful technique without analyzing these parameters. So I think that the influence, if you can see Stephen Nakada, you know, it's a giant in endourology from the United States. I'm sure the Professor Zeng knows him. So he described the influence of renal anatomy. It's very clear for low pole anatomy. And maybe this influence, you look to the angle, acute IPA, less than 90, it's a tragedy. Stones and lower pole larger, also it's a problem. So I think that we must discuss with many, you know, many features. I mean, we cannot discuss, okay, for all stones I apply this one and this one. I disagree. So if you look to this method, yes, in stones, in big stones, I try to make this pass the ball. If it's not possible, I fragment the stone, and after that, I move the fragment in the lower, in the superior, and or in the pyelic system, and not a problem. I can treat without problem, not in the lower pole, because it's sometimes difficult, very difficult. And I can show you here some such cases. Okay, look what it happens sometimes. Look to the ureter. You know, I try to treat this stone here, but look, the fiber laser was broken. And when I tried to destroy the stone, I destroyed the flexible ureteroscope. It's possible. This is the reality. And that's why, once again, I appreciate very, very much the presentations of Professor Zeng. He presented clinical cases. This is, after me, the best presentation and the best message. Look what I realized. Of course, 20 years ago, look here, 20 years ago, they compared mini percutaneous with standard, and it's clear that at this time they found that is no advantage to use the small access vasovagal scarring alone. This was 20 years ago, but nowadays it's clear. It's another story. I completely agree with Professor Zeng. Miniaturized PCNL represent a valuable new tool. And I like also these new tool, all these new tools that he used. Exactly, that I told you. And Professor Zeng presented us lower morbidity, uh, uh, so better stone clearance. Okay, there are some advantages, but if you look to this blood loss, no. Uh, Regarding the pain, I'm not sure. I see in our study after PCNL the pain is higher. It's clear. The nephrostomy. Maybe you can use without nephrostomy. Okay, but there are some complicated cases in which you are obliged to use nephrostomy. So it's another problem. You give to the patient another problem. Okay, and of course regarding the residual fragments, I agree. So if you look here, it's clear in the paper that already Professor Zeng show us. I appreciate a lot the comparison of efficacy of ultra mini PCNL. I like a lot this method. I appreciate a lot. Who is flexible. If you look here to the Clavian grading system, what can you see? Is Professor Zeng. He wrote it. Please, 16.67 for UMP and only 8% for flexible ureteroscopy. Look to the stone free. Okay, I agree with Professor Zeng, but look to what he published. For UMP, 98%, 92% is not a huge difference. Good. Let's see about new articles. Lower pulse stone between 10 and 20. It's clear the stone rate for low is better than flexible ureteroscopy. This is all the papers describe this, but the anatomy is the key. I have to say once again, the anatomy, the structure, and the volume. We have 3 parameters, and maybe you agree with me that these are the main important parameters. You cannot, compare mini with flexible without these parameters. You cannot compare, it's clear. So the stone free rate rate is like this. The stone recurrence is also described here. And what about all-seeing needle? I saw. I am totally agree with Professor Zeng. It's a good thing. It's clear that for micro PCNL, all-seeing needle, it's okay. The results are better. Yes, this is clear. Okay. And if you look here, you can see the difference about overall stone free rate, all seeing needle micro and micro PCNL. It's absolutely clear. What about mini PCNL offer a significant higher stone free? All paper describes this. Both, but look to somebody who analyzes these parameters. That I told you, both micro perc and flexible ureteroscopy are safe and effective alternatives and have similar clearance of the complications when you choose the right indications, when you choose the right patient, when you choose the right stone. This is my strong message for you. And of course, I put here also a study also from very recently, 2019, and it's clear here that both PCNL and REITs have some strong points in lower retreatment rate, and this is okay. I think that it's important to say once again. This is one of the main important slides. Look here. Our discussion, Professor Zeng and myself, you know, it's around the lower pole. And before us, the UK National Health Service wanted to know what is the best for patients, you know, and they launches a study. And look to this study. The recruitment is due to complete 30 September 2020. I'm so curious to know what happened in UK, because you know you can see here the lower pole of kidney, yes, and also the randomized study between flexible and mini PCNL, and we will see this. So this slide maybe it's one of the red fire in our presentation. And look, another slide, you know, no significantly different. I mean, in overall stone free rate, look to the mini PERC, 93, reals 90. Look to the overall stone free, yes, 95, 93. I mean, at the second month postoperatively. This is for the first month. So we have to wait a little bit in when you practice flexible ureteroscopy. It's not like that, you know, like in percutaneous approach. In percutaneous approach, you see the stone, you disown the stone, and okay, like Professor Zhang said, one shot, one result. Good result, no stone. But for flexible, it's another story. For flexible, you have to wait a little bit for the final results. So I give you 4 examples in which I have doubt about, you know, the mini or super mini or what you want to say, you know, in very challenging cases. In cases with bleeding disorders, we have a lot in Romania. We have a lot in Europe. There are a lot in the United States, a lot. More than 30% of patients, it's impressive. And look to the skeletal deformities and obesity. I told you, 30%, it's huge. And also some renal abnormality, I told you, and I presented you some examples. But in the end of my presentation, in this moment, I mean, in January 2021, I think that maybe we have 2 winners for lower stone. Maybe for 2 centimeters, my first choice could be also mini PCNL, also flexible ureteroscopy. But once again, with very, very attentive indication, which analyzes the features of anatomy, the structure of the stone, and the real volume. Once again, I totally disagree with EAU and AAA guidelines. I proposed to them many times, and in the last year also, to change, you know, the indication and the evaluation, the real evaluation of the stone. Thank you very much for your attention. So, Professor Zeng, what do you think?
Okay, I continue my presentation. I have 2 minutes.
Okay, next.
Excellent. I am waiting.
Next each speaker have 2 minutes for rebuttal. So first, let we invite Professor Zheng to rebuttal. So please.
Okay, many thanks for Professor's excellent presentations. For medicine to symptoms response, I think a mini PCN is not complete window. Okay, how to make a mini PCN and procedures become complete winners? Sometimes you can use my new technique, super mini PCN, SMP technique. Maybe you can make this complete winner. Okay, let speak louder than words. Okay, let us see this international multiple center randomized clinical trials for SMP compared to flexible for for less than 2 centimeters local stones. You see, for SMP is biaxial sound X-ray guidance, 14 flange irrigation suction sheaths, and the home laser for nasal trips, and is patient is stone flare, low bleeding, and low perforation, and to tubulus or total tubulus. And for flexible uroscope, maybe I use sheath, home laser, dusting, and the black, and after operation, put the digit placement. And you see, this compared the SMP to RIS for 1 or 2 centimeters local stones. This is multiple. This is a multiple central RCT. You see, this is outcome. I think compared to SMP flexible for less than 2,000 local stones, I think SMP is more effective in stone flare. SMP has less the treatment rate, and the complications and the hospital stay is the same as the flexible urological, but the low blood transfusion in SMP procedures. But as in flexible urological RIS has advantages of less pain. This is good. For this case is male, is 20 years old, sold to the kidney, and this multiple stone, the local stone, but sometimes this stone is moved down to the upper ureter and cause the patient no urine, and then they come to the hospital for emergency digit placement for 14 days ago. And for this patient, my first choice must be flexible uroscope, because this patient put a digit stand, ureter condition is very rare. You can put a sheath really easy. So I put first I try to flexible uroscope. You see, I put a sheath, and you see this is stone is down to the lower pole, but this IP angle is so acute. I can try many times, cannot reach this lower helix and the stone. And for this, how to do? I turn the patient to the prone position, and this I make 2 punctures SMP, and the totally tubulus. You see, no stand, no no tubal, and the totally tubulus, and the patient is stay one night, and the next day go home. So for my choice, for less than 2 centimeters local stones, SMP is my first choice. Sometimes for this AP angle is good, is not too small, maybe I can do flexible urological. Maybe. I think, Professor, I think it's a win to win. Okay, thank you.
Okay, Professor Zeng finally provided the presentation to show the mini PCL is his final choice, but not the regular mini PCL. It's the super mini PCL. So next, let's invite Professor Garrett to rebuttal, please.
Thank you very much once again. And a lot of sentences, a lot of slides that Professor Zhang already presented, I completely agree with him. But, you know, in life, it's a but. It's not possible to be perfect. You know, every time we said in Romania, oh, it's good, it's nice, I appreciate, I agree, but when I say but, it's already a problem. Let's see. Look, smaller truck size, wonderful. You know, less complications, I don't know. I'm not sure. Less breathing, not at all. Less invasive, I'm not sure. Less sepsis, I'm not sure. Quicker return to work, I am not sure. So 1, 2, 3, 4, 5, in which I have a big problem, and we could discuss about that. You know, I put this very interesting image. PCNL, how small can you go? Ah, it's good. You can go. Look, my friend Ralph Kleiman. I think that you know him many years ago. It's a picture with him, and he presented. Look here, from knife to needle to nothing. This is the evolution. This is clear, the evolution in life. I'm so sorry. And look here, standard PCNL, good. Mini, wonderful. Micro, oh, it's amazing. And here, nothing, zero. Where is the puncture? If you look here, yes, I put here exactly and very well calculated the diameters, you know. Here is standard, and of course, ultra mini, super mini, micro mini, mini, super mini, absolutely impressive. Look here, it's unbelievable. If you look here, it's standard, okay? And after standard is mini, okay? And after mini is micro, okay? And here, yes, this is the future. No PCNL. This is the new sentence. No PCNL. Good. And if you look here, mini PCNL, Professor Giusti, he said like that, as such, we no longer perform mini percutaneous instead, use tubeless PCNL when possible. This was in 2007. Okay, the time it's in favor of new. Thomas Knoll. Thomas Knoll is one of the best in EURIS. And he also said like that, maxi complication may occur even with micro access. I think that you agree with me that in our, you know, in our life, we have complications. Because somebody without complication, please run, because maybe he don't operate. It's clear. So complications, this is a real problem for us. And look to this slide. You know, some years ago, I was with Professor Arthur Smith in Orlando, and he awarded me for a presentation. Okay, and his sentence in these days, the only absolute technique to prevent hemorrhage after PCNL is not to operate. So, okay, this was in 2009. Now it's totally different. I agree with you. So, look to this slide. It's really amazing experience here. I mean, this was a webinar in January 7, 2021, this year. And if you look here, you can see ultra mini PCNL enhanced super mini PUSEN, endpoint, endpoint, endpoint. Professor Lame, you know perfectly Sven. Okay, best approach for me is mini PUSEN. But all this, when? In 2021. It's end, end, end. So I think that if you look here, wow, this is three punctures. Okay, and this multiple punctures. Okay, but I prefer wheels. I am sure that also you prefer this because wheels without punctures, is so nice. Me, myself, I prefer flexible retroscopy. So if you look to this one, I show you Shakira. Shakira is one of the best in the dancer in the world, so flexible, so nice, so effective. And here it's a photo with near Professor Lingemann, who was the president of AUA. And also he said that, okay, percutaneous approach is good, but I prefer ureteroscopy. So this is my rebuttal. Once again, I think that, in these days, nowadays, uh, the percutaneous approach, it's a wonderful, wonderful method, but with indications, with very clear indications. Flexible ureteroscopy, it's wonderful. I think it's absolutely great, but also with best indications. So once again, thank you very much for your attention.
Thanks for the Professor Gabriel. It's very excellent, relevant. So, Professor Matascu, what do you think about this session, Professor Matascu?
I think it was some great presentations, and you can see the experience behind these presentations in both techniques. And of course, the best technique to use is the one that you feel more appropriate to yourself, to your style, to your experience. But nevertheless, it was great to hear both arguments, and I think that both are winners today.
Oh, okay. Next, let's move to the third session. It's case discussion session. Next, we welcome the two moderate, Professor D. Gu and Professor Jax, to moderate this session. Professor D. Gu have something and need to handle, and we'll come back soon. So, Professor Jax, please moderate this session first. Thank you.
Thank you very much. So first of all, I would like to thank you for this excellent meeting. Both presentations were amazing. So now we can go to the third session with some case discussion regarding our experience, and we'll start with the experience of our friends from China, and Dr. Wen Zong will present us a clinical case.
Thank you. Good evening, dear friends and dear professors. So as you know, it's getting later in China. So now, thanks for attention. I would like to introduce this case for discussion. It's a male, 65 years old, and he has received a kidney transplantation 10 years ago. They are complaining about distal stone found in the routine body exam. No hematuria, no pain, no fever, or the symptom in the last 2 years. So we can see this from the QB. We can see the distal stone in the right side. The stone side is about 1.5 centimeter and 1.6 centimeters. And we didn't find any positive finding in the label exam. The renal function is normal and the urine culture is negative. So this the CT scan, we can see the distal stone. The size is UB, and the stone is a little bit red. It's about 1,200 here, and we can see mild hydrolysis and dilated ureter, and also we can see the reverse implanted claim. So for this case, how to manage? We have different choice. We have 3 minutes for discussion. Dear professors, what's your opinion?
Professor Javleta?
Oh yeah. So you know already my opinion. So I think that you know, maybe we don't have a great experience with SWL. You know, maybe it's possible to indicate. I don't know, in China, you have a great experience with SWL in such cases. What do you think, Professor Zhang? Do you have this experience?
I cannot tell answer. I cannot tell you.
Because Professor Zhang do this case.
No, but it's interesting. You know, I don't know. Maybe ureteroscopy. It's okay. It's a good choice.
Yeah. You can try. The first choice maybe URS. Maybe.
Yeah.
For me, the URS.
Yeah. Exactly. Good.
Okay. Thank you.
Răzvan, what do you think?
Yeah, I think for me also retrograde semi-rigid ureteroscopy is the first choice. The volume of stones is a little bit higher, but I think it's doable.
Okay, continue. So our practice is about we first try to do the retrograde uroscopy, but also we follow with the retrograde flexible uroscopy because the ureter orifice in this transplanted kidney is on the top of the blood. We cannot insert the guidewire, we can insert the uroscope. So we have to transfer to plant B. Because we failed in the retrograde way, we have to try to in the antegrade approach. So we have another case, a successful case for transplanted kidney. Firstly, we do the puncture from the pole, and we try to insert the guidewire through the needle to the ureter, and the guidewire passes the ureter to the bladder. Then we pull it out from the urethra. So in this situation, we can insert the uterus sheath retrograde, and then Professor do the flexible uroscopy successfully to treat the renal perfect stone in this transplant clinic. So, but we were not lucky in this case. So we can see that we do puncture from the upper pole, and this we will inject contrast to the renal system. We can see the ureter is very tortuous, so we cannot insert guidewire into the blood. Now we try to insert the guidewire from the first uroscope. We can see the total ureter here. Then we try several times, but it also fail. Then we change to the disposable flexible uroscope. So for this case, so when and why we have to use the disposable flexible uroscope, and how to access to the stone in this situation? Any suggestion?
Yes, it's a very good case. We had such cases. I think we had I don't know the number, but many cases like this, in which you know the guidewire you can pass anterogradly. I mean, like you. So using this possibility, you can reach the stone and you can treat. I don't know why you have these severe ureteral bleedings. What happened? Because it's so unusual. Uh, I don't know. Can you explain what happened endoscopically?
So because the total is ureter, we cannot insert guide to the ureter and to the bladder, so we cannot insert the sheath.
Yes. Yes. Okay. So in this case, at least in our experience, I think that is necessary to put a nephrostomy. Wait, I don't know, 2 weeks, 1 month, in order to have your kidney in your hands and to have a good drainage, and in order to measures to be stable. I think this is the first thing that we will make. After maybe I don't know, 2-3 weeks, 1 month, I treat without problems endoscopically this problems that you have.
Okay, good suggestion. So another opinion? Now we continue.
Yeah. What you made?
In this case, we cannot insert the guide wire from the flexible ureteroscope. Then we try to insert the guide wire. We change another hydrophonic. It's a hydrophonic guide wire. So in the nephroskop, we insert the guide wire to the ureter and to the bladder. Now we can pull it out from the urethra. Then we try to insert the uterus, flexible uterus sheath to the stone. Now you see that this is the integrated port. This is the retrograde port. So we both in this situation we can get close to the stone, but it's very hard to break stone with the horizon. So my question is that why we cannot break the stone with a flexible scope? So, and what's the next step to treat these stones?
Okay, so once again, failed. I don't believe it. So it's a nightmare. It's a nightmare for you. And now for us.
Yes, it's a nightmare.
And now for us. So, maybe no open surgery for me is not a possibility. No open surgery. No. This is my first sentence. The second one, maybe I will try to put a double J. You know, I have the guide wire. You pass the guide wire, and I can put a double J. Yeah, and I will wait. In your case, you must wait, wait and wait and wait.
Wait how long? 1 year, 2 years, 10 years.
Yes, it's a good idea because we have to stop. In the operation, we cost 2.5 hours. We cannot treat this stone in the retrograde way or in the antegrade way. After the operation, I think we have a lesson from this operation because the tip of the sheath is very close to the stone. I think there's no space for the flexible scope. To get close to the stone, and I think this is the lessons. But at the beginning, for me, I think we can try to get we can try to treat these patients with ESW, but without stent, we cannot to do the ESW because the fragments will cause bring acute overcharging for this case. It's a transplant kidney. It means that it's a solid kidney. Obstruction will bring the renal failures. So, but after the operation, I think we can put a double stent because it's a stent can for drainage and also the mechanism too for drainage. Now we can have time to think for the next step. But for this case, after 2 times for the flexibility score, it's all failed. So we have to think for ESW. This is the first time after ESW and the second time after ESW. So the stone is free after 2 times ESW. I think this is the best result for this case.
Yeah, congratulations. You know, once again, my first question, if you remember, was what is your experience with SWL?
Yeah, it's a very good choice.
Yeah.
It must let everybody know in Indo-urology area, in Indo-urology times, you never forget ESWL shockwave is good. Sometimes you can try. You can try.
I completely agree with you.
Don't forget. Yeah. Don't forget this technique.
Very good.
Okay, thanks for attention.
And now Dr. Mulțescu with another clinical case with flexible retroscopy.
Thank you. In order for me to share, yeah, great. The other share should stop. Okay, I think now you can see also the presentation, right?
Perfect.
Okay. So first I want to say that it's a great pleasure for me to be part of such a great webinar today. Experience. And the clinical case that I want to present to you today is a case which raises questions in everyday life. It's a case of bilateral renal stones in a patient with recurrent UTI. 60 years old female. Actually, she's a doctor, a radiologist, with a long history of urinary tract infections and renal stones, which had some left lumbar pain in the last 8 days. And since 2 days ago, also right lumbar pain. In the last 24 hours, she experienced fever and chills, and the KUB showed radio-opaque images on the projection area of both kidneys and left ureter. And also, if you can see in the image, she has also very severe scoliosis. A CT scan, which was performed, described bilateral second-degree hydronephrosis, 13 with 9 millimeters left inferior calyceal stone, an 8.5 millimeter stone on the left ureter, and on the right side, a 29 with 17 with 13 millimeters right pyelic stone, and also inflammatory changes in the right pylocalyceal wall. So not the biggest stones that we treated, but also still a large volume of lithiasis. And the preoperative cultures and also the intraoperative cultures describe multiple drug-resistant Enterococcus fecalis. So in the first step, we try to be as less invasive as possible because she was infected and she was septic. So we perform ureteroscopic removal of the left ureteral stone and double J stent insertion on both sides. And after a period of time, after 2 weeks, and some targeted antibiotics for the Enterococcus. When everything was now cold from the infection point of view, we perform bilateral double J stent removal and flexible ureteroscopic approach with holmium laser lithotripsy of the stones on both sides. As you can see in the image, despite the fact that at this moment the urine culture was sterile and that she had some targeted antibiotics for her infection, the urine is still cloudy, and I think it's reasonable to accept that in large stones, even if you can achieve temporary sterile urines, there are still some germs inside the stone that will surface when you perform lithotripsy. We perform dusting lithotripsy in these cases because the stone volume was a little higher, and we try to not to make a lot of passages through the ureter. We use the ureteral access sheet to decrease the pressure inside the systems. And at the end of the procedure, as you can see, there are a lot of very small 1 or 2 millimeter stone fragments residual. This is an image from the right side. And we inserted new double J stents bilaterally. 1 month passed since this intervention. A little more than we planned initially, because when she was due to return after 2 weeks, she was positive for COVID-19. So we had to delay the 3rd intervention with 2 more weeks. And the urine culture, not surprisingly, described the same multiple drug resistant Enterococcus fecalis. And also, if you can see on this KUB, both double J stents inserted correctly. No images suggestive for residual stone fragments on the left side, and on the right side, you can see multiple small residual fragments, small but multiple, alongside the double J stent in the below the UPJ, and also on the iliac, in the inferior lumbar segment of the ureter. She also had the CT scan. This was not mandatory from my point of view, but remember, she was a radiologist, so she decided to perform also a CT scan. And the same findings, good position of the double J stents and some residual stone fragments on the right side. In also, if you can see on the CT scan, also on the pelvic segment of the ureter. The urine culture described the same multiple drug resistant Enterococcus fecalis. So now came the dilemma. What should we do next? Just because the stone fragments were very small, just a bilateral double J stent remover, or also to associate active removal of the restant stones? If professors can comment on this.
Okay, I think this you must remove the DJ stent both sides, because you DJ stent inside maybe caused more and more infective. You always urine culture positive, level negative. So you must remove this DJ stent. Another question: you do stone culture? You do stone culture? Stone
Sometimes
culture?
yes. Yes, sometimes yes. More in cases of PCNL with large volumes, especially in staghorn calculi. I think stone cultures from stone fragments may be useful, but in this case, not really, because it was her germ. She knew about this MDR Enterococcus for a long time. So it was safe to presume that this was also inside the stones.
Yeah, that's true. In our department, not all not all cases for stone culture. For sometimes Stackhorn infection stone to stone culture. It's the same as you. Okay, I think you must remove.
Okay. Professor Jablete, if you can comment.
It's clear that you know, sometimes, and this is the message from our experience, is that sometimes, you know, without removing the stone, you cannot sterilize the patient. It's up. I'm so convinced. There are a lot of stones, you know, with so-called sterile culture urine, and after operation sometimes, and you know, we try, if I remember well, to send some fragments of the stone in order to see if in these stones are, you know, maybe infected. I don't know. This is an experience that show us that in many cases it's possible when you treat a stone to obtain not only dust but also a lot of bacteria.
Yeah.
You know.
True.
So, yeah. So I don't know in PCNL how it is, but in flexible ureteroscopy is like this.
Yeah, I felt the same, that first we have to remove all the foreign bodies, stone fragments and double J stents in order to have a significant chance to make the urine sterile on the long run. And also I felt that the risk of septic complications, if this patient had even for a short period of time obstructive obstruction on the upper urinary tract, would be very high. So I also choose to take out the double J stents and to remove all the stone fragments. As you can see, small ones, easy removable with a basket, but complete removal of those fragments. Of course, as usual, it happens usually the last fragment migrated in the pilocalyceal system, so we had to insert also the flexible ureteroscope and take it out. And at the end of the procedure, the patient was stone-free. Her evolution was simple. At the postoperative evaluation, imagistic radiologic postoperative evaluation, she was stone-free, and finally the urine cultures were clean, were sterile. So thank you very much for your attention, and if there are any other comments or questions.
You do stone analysis. This stone composition is infection stone.
I believe that every time that is possible, we should do that. Some stones are very suggestive from their appearances, you know, like this stone. This stone was probably discussing from the appearance. Calcium oxalate dehydrate, and of course with some infectious stones. But I think that even when the aspect is very suggestive, we should do the biochemical analysis, because it's very important. If we find that in evolution the patient has a high potential of recurrences, of stone recurrences, to have a starting point to do the metabolic evaluation, and then to offer him some prophylaxis. You know, it's we like a lot to operate, and yeah, I think this is the meaning of our specialty. But I think that we should take care not to operate too many times on a patient. We can offer him some solid some solid ways to prevent new stones to recur. Then we should do that. And the biochemical analysis is very important in this point of view.
Okay, good. Okay, good. Professor, you make a summary because it's too late. In China, it's 11.
Yeah. Rezvan, please yes, close your presentation. Yes, and this one, perfect. Yes, I
Yeah.
have only some slides in order to show together. I prepare especially for this webinar, closing remarks, and we are together. Yeah, we are together in the same path. So this is, yeah, one of my main messages. And it's clear that different miniaturized percutaneous nephrorectomy versus retrograde intrarenal surgery. We already discussed all the problems. So this is practically a summary in 2020. And I put here your paper, which you describe here over a stone friendly SFR. It's okay in favor of your technique, but the publication not. Of course, no statistical significance. And I put here a nice paper also from you, in which, of course, you describe, the minimally invasive nature is potential superiority in terms of safety and efficacy. And of course, I think that this super mini PCNL in 2015, I know this from some years, and I appreciate a lot your ingenuity and your techniques, and ultra mini percutaneous nephrectomy seems to be also quite nice. So, article of the month in December 2017 synthesize exactly that I told you, the overall stone-free, the auxiliary procedures, and the complications were discussed. But if you look to this for flexible retroscopy, also EU and AVA recommends without problems, no contraindications, flexible. And the key of success of flexible is the speed and quality of dusting. This is I'm so convinced about this, and the real stone-free patient. These are even no dust remaining. This is in fact our dream, because I put here the ideal ureteroscope. I need this ideal ureteroscope in order to fight with any percutaneous approaches. I need this diameter. We are very close. 7 French. Perfect image. HD. Yes. 4K. In progress. I have to inform you. Flexibility. I need double angulation. In cases that you cannot reach the stone in the inferior calyx, with double angulation is possible. This is a dream. Redundancy. Of course, we have single use in our hands. Of course, we have robotic. This is absolutely great. And I am so delighted with robots. Cost, yes. Regarding the cost, I completely agree with you. This percutaneous approach, it's much is not so expensive. Better laser, we already have. Suction, yes. This is the magic word. So, my dear friend, my dear Professor Zhang, the magic word in the end of this webinar is how we can suck all the fragments. I mean, also dust, also little fragment. Because when I will have this with ureteroscopy, this will be the best of the best. No problem with any other method. Okay, so I put here some of our new PUSEN 7.5 in January 21, and our experience, first Romanian experience in 21 will be with new super pulse Saltive. So my message is this slide. I think that PSA for stone is the personalized stone approach. This is the new mode of thinking. PSA for stones. And maybe this is the future. Of course, single use, dusting laser, robotics, full stone free. And this is that I told you. And finally, you can see here, I don't know if you like Formula 1. It's quite nice, quite good. And here I am, here you are. You know, it's I think that this real debate of these two methods are very close and very effective each to other. Once again, look, these stones that you showed us, I don't believe that will be in the future. You know, earlier diagnosis, this is the evolution in the world. It's normal to have a diagnosis before you get this stone. It's normal to have little stones and to treat. How can you treat? With flexible meteoroscopy, it's clear. And once again, my last slide, I learned Chinese and I can say to you, xie. I think that I pronounce good. Sorry about my pronunciation, you know, xie.
You speak Chinese really well. 谢谢. Thank you. Very nice, very excellent closing remark. Because I think PSA in stone disease must have a good future. PSA is right. Yeah, I think it's good. PSA, yeah. PSA, not PSA. PSA is good. Good future. I think PSA is good. Yeah. Okay. Now time is too late for me. For us, maybe.
Excuse me, Professor Zhang and Professor Javelit. I would like to congratulate that tonight is a very wonderful night for us. And tonight in China, we have almost 2,000 audience watching our webinar tonight. 2,000. It's a very successful webinar for us. Yeah, thanks to all of you. Thank you.
Thank you very much. And once again, thank you, Jeremy, and thank you, Professor Zhang, for this opportunity. Great. This bridge in Romania and China.
Together.
Okay.
朋友 together. Friends together. 朋友 together. 谢谢你.
Yeah. Thank you.
Thank you. Bye. See you.
Goodbye.
Thank you. Goodbye.
Take care. Keep safe.
Take care of you. Okay.